जैसे मैंने बोला था एक डेट फिक्स करने के लिए, सरिता से बात करने के लिए बुलाया इसको आपने, क्या दिन फिक्स होगा बता दीजिए।
हेलो, आप बोलिए। अरे सर मैं चल रहा है ना, एक बार आप क्या बात सुनने थे एक बार। अलीशा, हेलो।
I think my camera is not okay because I'm not visible properly. I'll have to adjust the camera.
Dean sir is here, so I think we can start. Rama, are you there? Rama?
सब तो दिख रहा है इसमें, हैं? सब दिख तो रहे, आवाज भी आ रही, आवाज नहीं आ रही तो
रमा, डीन सर को बुला लेते हैं. I think we can start.
ठीक है.
Adjust myself. मेरी तो बॉडी, my camera गड़बड़ है.
तो डीन सर,
I'm here.
सर हम स्टार्ट करें?
बिल्कुल. Your function, you start whenever you want.
मैम, हम स्टार्ट करें? ओके. रीना मैम?
Yes, I'm here.
हम स्टार्ट करें? ठीक है मैम. So good evening everyone, and wish you a very happy Holi in advance. Hope everyone is fine and healthy. This is our second webinar of this year 2021, and the occasion is World Tuberculosis Day. As you all know that the tuberculosis is the deadliest disease on the planet, and it is a potentially fatal contagious disease that can affect almost any part of the body, but is mainly an infection of the lungs. India is the highest tuberculosis burden country, accounting for more than 1/5 of the global incidence. The Indian government is committed towards ending tuberculosis by 2025. For tackling tuberculosis menace, rapid diagnosis is key. Today, with all our eminent speakers and panelists, we are going to discuss what makes tuberculosis the world's most infectious disease, and how medical advancements are improving treatment, and also why the fight against this disease is far from over. This year, World Tuberculosis Day theme is TB Harega, Desh Jeetega. So we all should join together for the eradication of this fatal disease. Now I switch over to Dr. Pyali, our chairperson, for this webinar. So for the welcome address. So welcome Pyali ma'am. So over to ma'am. Thank you.
Thank you, Rama. I welcome all the eminent speakers over here, and Dean sir, and request his blessings. Professor Mishra sir?
Yeah, just 1 second. Setting my connections, okay. Good afternoon to all of you. Nice to see this. The event is happening regularly in a very sustained manner. And people are doing a very excellent job remembering this day, which is internationally celebrated. Remind all of us that the problem of tuberculosis needs to be taken care of. I don't know whether in my lifetime we'll ever see that tuberculosis ever be eradicated from this country. This is not a very simple thing. All of you are experts in your best. you must be aware that tuberculosis itself is not only just direct disease from infections, it's also aftermath of so many other diseases which is related to the cause of tuberculosis. Many of the immune suppressed conditions, those are very critical nature, like in current days of transplants, and also so many other things are happening causing immunosuppression because of diabetic issues. So tuberculosis is going to stay, and I think you have to just contain it, just like you're trying to contain the COVID, I think. So what is more important is in our institute we have, I mean, of course, tuberculosis involves all the departments. Every department has a quota of treating tuberculosis, starting from the brain, tuberculosis, meningitis, encephalitis, to down below to the toe. You can have tuberculosis anywhere. That's the peculiarity of this disease. We also have this share in my specialties, though it is very uncommon, but it happens. So what I think SGPGIs do, because we are really institute of different kind. In the shadow of super specialty, we really do a lot of injustice to many of these public health problems, which you are not able to tackle actually, because for tackling the tuberculosis also we have a great role to play in the field. I was just discussing with our director a couple of days ago when I came to know about this event. So should we take our mobile van and go to the field? Dr. Ghosal is also going to do, and we're interested in the luminal gastroenterology and so many parasitic diseases, etc. We are very interested. And our country, the rural areas are infested with all these problems. So can you do something? We're taking this mobile van that we have. And the answer that I got from our director is, who will go? That's the first question he asked me. So who will go? Even if I say that, okay, Dr. Piali or her team in General Hospital are steering this program, can they remain absent from the clinics to go to the field? And we do not have really a department of a community epidemiology. That's very important, clinical epidemiology unit. Dr. Ghosal, you are listening to me. I think in the next meetings of Research Council, maybe can think about that new specialty, that whether it is gastroenterology, parasitic problems, or it is tuberculosis of the lungs, or tuberculosis of any other organs. I think our institutes play a big role. So we have the top of the brain, and being super specialty, we can do a lot of things in the sense to investigate difficult tuberculosis, resistant tuberculosis, which cannot be done in any other institutions. So that is, I think, all of you to debate and discuss. My only request is that all of us should combine together, because you believe your passion for managing tuberculosis problems, whether it is in the community or in the hospital, to see that how SGPGI can play a big role in the control of tuberculosis and contribute in a small way to the international war against the tuberculosis. So with that, I wish the event a great success, and please continue holding this thing every year, reminding all of us and letting us know what SGPGI is contributing in the past year. Thank you.
Thank you so much, sir, for your blessings and kind words and words of advice. So, our moderator is Dr. Prerna. And Prerna, everybody knows Prerna, so I don't even need to introduce her. She has been our physician, she's been a personal friend, and I would say the greatest physician on earth. So I will hand over the mic to Prerna today to moderate the session. Prerna.
Thank you, Dr. Piali. I hope I'm audible. Am I audible?
Yes, you are audible. Carry on.
Oh. So, good evening, everyone. On World TB Day, we have a meeting every year just to create awareness about this disease, which unfortunately is still rampant, which still affects all the organs of the body, almost all age groups. However, Indian government is committed to ending TB by 2025, which is 5 years ahead of the global target. So who better, I welcome all of you for this discussion tuberculosis and various forms and regional organs. The person who I would welcome to start program today is our STO, State Tuberculosis Officer, Dr. Santosh Gupta. He has a very long experience of implementing and monitoring public health programs in India. While he was with WHO, he also coordinated polio eradication and immunization activities for many, many years in the states of Jharkhand, Bihar, and UP. And it is under leadership now that our national TB elimination has witnessed a lot of improved laboratory network, private sector engagement, coordination, community participation, programs like today, etc., etc. In short, today is a very big for Dr. Santosh Gupta as well as for Kant. People who sort government, doctors, and the private practitioners and the community. So I welcome all of you. I welcome Dr. Santosh Gupta and invite him to deliver a talk on the situation of tuberculosis in India, and moreover, the importance of NTEP, the National Tuberculosis Elimination Program, what it does, what are the ramifications, and what is our commitment towards it. Over to Dr. Santosh Gupta. Over to you, STO, sir.
Thank you, Dr. Kapoor. I'm thankful to SGPGI administration, Dr. Piali Bhattacharya, and the organizers who have invited me for sharing the status of NTEP, that is TB elimination in the state of UP. In next few minutes, with the help of a short presentation, I will be sharing where do we stand as far as TB elimination is concerned. So I am sharing my screen so that we can go through the slides. Yeah. Yes. I think I am audible to everyone. And can you visualize this slide showing Delhi NTB summit with Prime Minister Modi ji?
Yes, sir.
Okay, ma'am. So just to set the background, where do we stand as a country? And this has been beautifully depicted by this Venn diagram. India has been put in the centermost part of this diagram, along with several African countries, Angola, DR Congo, Ethiopia, Kenya, Mozambique, Nigeria. And we have been put in this place just because we are load of tuberculosis, we are having very high load of MDR TB, as well as TB and HIV comorbidity. We are contributing to 27% of the global TB burden, and 20% of the disease load of the country comes from our own state, UP. If we talk in terms of absolute numbers, and here are the numbers, and you see that in year 2018 and 19, we got significant improvement in the case notification. You all are aware that getting notification of all the cases is a very important aspect for this program, because as soon as we get the notification, we try to link that person to the various facilities being provided under the program. So we made concerted effort to increase the notification from the public sector as well as from the private sector. And in 2018, we got a jump of 38%. 2019 witnessed an incremental jump of 19%. and we got maximum notification, that is 4.8 lakh cases. But 2020 was entirely different year due to COVID pandemic. Lot of OPDs suffered in public sector as well as private sector. We could not get notification as expected. But even in the post-COVID period, we have made extensive efforts. Several specialized campaigns were launched with different names: active case finding campaign, TB Harega Desh Jeetega campaign, and right now we are going through the Dastak campaign. In all the campaigns, we made efforts to identify the cases which could have been missed during the lockdown. And as a result, 2020, we identified approximately 3.7 lakh cases. And this year, till now, we got the notification of about 1,05,000 cases. And in this 1,05,000 cases, 76 cases notified by SGPGI are also included. I repeat, in 2 months of this, initial 2 months of this year, January and February, the program got notification of 76 cases from SGPGI. So many, it's such a big institution with so many departments, so many cases of TB coming to various departments every day, and the program has been notified only 76 cases in these 2 months, January and February. So I leave it to you. I do not want to make any value judgment, but I leave it to you. If you feel that all the cases from the SGPGI are being notified, it's well and good. And if you feel that you are still missing cases, some cases are not being notified, then my request to you is, please intimate all concerned that each and every case of TB, whosoever is being diagnosed or being treated at the institution, it needs to be notified to DTO Lucknow. If we break it in terms of the public sector notification and private sector notification, same story is here. Last year, we got 2,42,000 cases notified from the public sector, and there was a decrease of 26% as compared to 2019. This year, out of 1,05,000 cases, 71,000 have been notified by the public sector and 33,000 have been notified by the private sector. Our annual target for total case notification is approximately 6 lakhs. And even with the current trend, we are not going to achieve it unless and until institutions like SGPGI and KGMU ensure that each and every case being attended by them is notified to the program. Now coming to the various services being provided to the cases being notified to the program. You know, with that, our state is having significant disease load of drug-resistant TB also. In 2020, we could test 60% of the total 4.8 lakh cases for rifampicin sensitivity. And this year, during initial 2 months, this figure stands at 55%. HIV and TB, they are very closely related, and the program emphasizes that the HIV status of each and every TB patient should be known. We know HIV status of 91% of our cases notified in year 2020 and 90% of the cases notified in year 2021. Last year, we witnessed significant progress in our treatment success rate, and it stands at 83%. You all are well aware regarding the clinical aspect of the disease. But since I have got an opportunity, so I want to brief you regarding the various incentives being provided under the program, so that you can talk about these incentives and support us in generating awareness. You must be aware that the program provides an incentive at the rate of rupees 500 per month to TB patients during the entire duration of their treatment. This scheme is known as Nikshay Poshan Yojana. Nikshay Poshan Yojana, it is meant for improving the nutritional status of TB patients. And let me tell you that since the inception of this scheme in March 1st April 2018, we have disbursed approximately 200 crore rupees to 8.16 lakh TB patients of the state by direct benefit transfer process. There is provision of incentive for notification by the private practitioners. Each private practitioner who notifies a case, for each case notified by them, they are entitled for an incentive of rupees 500, and when they declare the outcome of that case, they get another 500 rupees for declaring the outcome. So for every case, if a private practitioner notifies the case and at the end of the treatment notifies the treatment outcome also, then he gets 1,000 rupees in 2 installments of 5,000 each. For treatment supporter, there is provision of 1,000 rupee for drug sensitive patient and 5,000 rupee for drug resistant TB patient, and informants are also entitled for incentive at the rate of rupees 500. But these Nikshay Poshan Yojana is for TB patients, and the incentive for informant, incentive for notification, and for treatment supporter is applicable for relevant categories. But the rider is that the person who is being paid these incentives should not be getting salary from the exchequer. Let me tell you the laboratory network, NTP laboratory network in the state. We are having one national reference laboratory at Jalma, Agra, 2 intermediate reference laboratories at State Training and Demonstration Center, Agra. Another is at Department of Microbiology, KGMU. We are having 7 culture and drug sensitivity testing laboratories. They are at BRD Medical College, Gorakhpur, IMS BHU, Varanasi, LLRM Medical College, Meerut, SRMS, Bareilly, and JNU, Aligarh. In addition to this, we are having MOUs with RML Institute of Medical Sciences, Lucknow, and SGPGI, Lucknow, for supporting the program. 4 more laboratories are being built. They are in the various processes of development at Jhansi, Kanpur Nagar, Etawah, and Prayagraj. These are the specialized laboratories, TB containment laboratories, or we call them culture and drug sensitive laboratories, and they are supported by 2,000 plus microscopy centers, 145 CBNAT laboratories, and 451 TrueNat labs. So an extensive laboratory network has been built in the state. Tomorrow, day after tomorrow, we are having a crucial meeting at Government of India in which the budget of the program for the state for next financial year will be finalized. And in this meeting, I am proposing 2 more laboratories. One will be at GIMS, Greater Noida. Another will be SGPGIMS, Lucknow. These will be BSL-3 TB containment laboratories. But before that, this has to be ensured that the tests being done in the laboratories, they should be done without any cost to the patient. These will be laboratories supported by National TB Elimination Program. For management of drug-resistant TB cases, we are providing services with the help of 56 district DRTB centers, 22 nodal DRTB centers, and 3 more nodal DRTB centers we are going to propose to Government of India day after tomorrow, and they will be coming up at Jalon, RML Institute, Lucknow, and Government Institute of Medical, Government Medical College, Banda. So with this, we will be having 25 nodal DRTB centers. Lot of political and bureaucratic commitment is there for the program. This is the picture when Honorable Chief Minister UP has launched active case finding campaign on 1st November 2020. On this very day, he unveiled the strategic plan of TB elimination from the state and launched delaminate-based regimen in across all the nodal TRTB centers of the state. Another picture indicating the lot of bureaucratic and political commitment. Honorable Governor UP Srimati Anandi Ben Patel ji launched another active case finding campaign on 2nd January 2021. In this campaign, we got notification of about 14,000 cases. Here are the details of those 14,000 cases. And now the program is at that stage where there should be a sense of urgency. This year's theme for World TB Day is the clock is ticking. The goal of TB elimination fixed by our Prime Minister is 2025. Last few months have been dedicated to COVID. Lot of programs have suffered, and I don't face any difficulty in admitting that there had been a blow to the TB elimination program also, though we tried to maintain the continuity of services to our TB patients, but still the notifications suffered. Now we are making utmost effort to bring back the program to normalcy, and for this we need to engage everybody. This year we decided to celebrate World TB Day over a week. On 18th March, we organized a CME for private practitioners. On 19th March, there was a big event at KGMU chaired by Honorable Governor UP. On 21st March, me and Professor Suryakant jointly participated in Mission Health episode on Doordarshan. 22nd March, me, Professor Suryakant and Piali ji, we all participated in an event for youth sensitization. On 23rd March, Honorable Health Minister UP briefed media regarding the progress being made by the state in TB elimination and appealed to all the stakeholders to come together for the cause of TB elimination. And today, on World TB Day, we had the main event in district Sitapur, where Honorable Chief Minister UP Shri Yogi Adityanath ji unveiled the network of 451 TrueNet laboratories, 25 digital X-ray machines established at district tuberculosis centers, LPA laboratories at Meerut and Gorakhpur, and a regional TB program management unit at BRD Medical at Gorakhpur. In addition to this, he appreciated 5 district tuberculosis officers under whose leadership districts performed well in year 2020. This is the photograph of event at KGMU on 19th March. This is the 18th March and 21st March event. 22nd March event in which you can spot Dr. Piyali Bhattacharya also. This is the picture of press conference done by Honorable Health Minister UP. And another area where lot of emphasis is being laid nowadays is the adoption of TB patients. This initiative was done by Raj Bhavan on 25th August 2019. Until now, various social, cultural and educational organizations have adopted more than 25,000 TB patients. Till now, this was restricted to pediatric age group TB patients, but today our Chief Minister has talked about adoption of all the TB patients. So in future, we will be working more aggressively on this aspect also. And this is a very good initiative because the person who adopts a TB patient provides emotional support to the family. Whenever he visits that family, once a month visit is expected. During that visit, he can take nutritional supplements and it acts as a bridge between the system and the patient. This, I would end my talk with sharing of this Gazette notification dated 19th March 2018, which speaks regarding mandatory notification of TB cases and prescribes certain penalties in the event of any act of omission or commission. So my request to you is, please continue to notify cases. Please ensure that each and every member of your team is aware that every case which is diagnosed or which is treated in the department is notified to DTO. This is with this request, I want to finish my talk. Thank you.
Thank you, sir. Thank you. Indeed, with a dynamic STO like you, UP is indeed a very, very, very lucky state, I would say. And you have enumerated so well all the steps that the government is taking towards elimination of TB. What I always say to everyone is, government or program, they are doing their best. Now the onus is upon the other stakeholders, that is the healthcare providers, the doctors and the community. This is our first now, because the government and the program are doing their best. Is patients को पोषण के लिए भी पैसा मिल रहा है, दवा भी मुफ्त मिल रही है, डायग्नोसिस भी मुफ्त हो रहा है, एक्सीलरेटेड केस फाइंडिंग भी की जा रही है टाइम से टाइम. सो अब मरीज के ऊपर ओनस है कि दवा खाए, डॉक्टर के ऊपर नोटिफिकेशन है कि करेक्ट डायग्नोसिस करके ट्रीटमेंट स्टार्ट करें. एंड वन वेरी इंपॉर्टेंट पॉइंट दैट यू एन्यूमरेटेड सर इज द नोटिफिकेशन. I think notifications have to go up, because that is what will really bring out the strength of the program. How many patients are we diagnosing? How many of them are actually culminating in cure, etc. How many took their treatment properly? How many of those were drug sensitive TB? How many of those were drug resistant? And उनका क्या हश्र हुआ? वो अल्टीमेटली ठीक हुए, रिलैप्स हुए, क्या हुआ? ज्यादातर आजकल ठीक ही होते हैं, हम लोग जानते हैं. So I think notifications definitely have to go up. On our side, we have to always be dedicated to make everyone aware about this, that notification of TB is a must. Whether you are treating the patient under the program or getting the medicines privately, notification of TB is a must. So this is something, yes, we need to emphasize again and again. We are going to try and emphasize it in SGPGI. The other carry home, sir, that we got from you is again that each one of you, because the clock is actually really ticking and we have only got 4 years left now. 2025 तक हमें टीबी को एलिमिनेट करना है, तो 4 साल हमारे पास बचे हैं एक्टिवली टीबी को एलिमिनेट करने के लिए. So the clock is ticking and we should all be working towards finishing this race well ahead of the clock. Thank you, sir. Thank you for that wonderful lecture.
And since I have to attend another meeting, so I would like to leave. Dr. Kapoor and Dr. Bhattacharya, please, if anything else needs to be from my side, or you have some good suggestion, kindly pass it on to me. Thank you very much. Thank you.
Thank you, sir. Thank you so much. And thank you for giving us your valuable time. We know that you have a really, really busy day. Thank you, sir.
Thank you.
I now welcome all our panelists for the next session of the program. After this very enlightening talk by STO sir, we now come on to the rest of the program. As everyone has always been taught during MBBS, TB affects all parts of the body except hair and nails, as Dr. Ajit will agree with me, our dermatologist. So keeping in mind that, and the fact that we all think that we know about TB, but TB still remains an enigma, especially various aspects of pulmonary TB and then different aspects of extrapulmonary TB. So keeping all this in mind, we have kept some very short lectures today, and I would like to welcome our panelists for today. Along with Dr. Pyali and Dr. Rama Tripathi, I'd like to welcome Professor Suryakant, Dr. UC Ghoshal, Dr. Pyali Bhattacharya again, Dr. Indulata, Dr. Vimal Paliwal, Dr. Amit Kumar, and Dr. Ajit Kumar. Some of them I can see on the panel, and some of you I can't. We are going to start with the first lecture, which is by Dr. Suryakant. Dr. Suryakant actually in Lucknow and UP, or in fact, I would say in entire India, knows no introduction. I'm going to just share a slide about, जैसा मैंने अभी कहा कि इंट्रोडक्शन की उनको जरूरत नहीं है, फिर भी हम इंट्रोड्यूस एक बार कर देते हैं डॉक्टर सूर्यकांत को. डॉक्टर सूर्यकांत, you are here and am I audible to you? I'm trying to, yeah. So this is the introduction about Dr. Suryakant. I hope it is visible. Okay. Hello, Dr. Suryakant. Good evening. You are not audible. Please, you have to unmute yourself. So Dr. Suryakant, like I said, needs really no introduction.
Can you hear me, ma'am? Can you hear me now?
Yes, we can very
okay. Namaste to everybody.
Namaskar, and we are actually looking forward to hearing from you. But first of all, I would like to tell the others a little bit about you. Though, like I said, you need no introduction. Dr. Suryakant is presently the professor and head of respiratory medicine in King George Medical College. He is the brand ambassador for COVID vaccination also under NHM UP. I would like to add here that in the last 1 year, Dr. Suryakant has tirelessly advocated for all aspects of COVID awareness and vaccination also, while keeping his finger on the pulse of TB in the state also. So that is something very enviable that he's been doing. He's tireless. You can see his videos on YouTube. You can hear his various very informative talks. He's very, very dynamic. And he's, well, the chairman of the UP State Task Force for TB Elimination, which I have to keep repeating that we are now committed to eliminating TB from India by 2025. So with this, over to Dr. Suryakant for his talk about pulmonary TB and why pulmonary TB has always been the thrust of TB control programs in India. What is the importance of pulmonary TB? Over to you, Dr. Suryakant.
Okay. It's okay. Thank you, ma'am, for a wonderful organization of very important academic awareness event on the World Tuberculosis Day. Everybody knows that tuberculosis is a major health problem since centuries in the world as well as in our country. And very important milestone which we observed, which the world observed rather on 24th March 1882 when the Robert Koch declared the discovery of causative organism of tuberculosis. So that was a very important landmark in the history of tuberculosis, I would say. And then again, another landmark came in 1921 with the invention of vaccine, BCG vaccine. And third important landmark is the 1943 when the first anti-tubercular drug came into the existence. With these three important landmarks in less than 50 years from 1882 to 1943, within 50, 60 years, we face then a lot of challenges, especially in the developing country. And the fourth important landmark, it's not landmark, it's a basically tragedy, I would say, that is 1993, when the WHO was bound to declare tuberculosis as a global health emergency. And madam, this emergency is continuing for last 28 years. So it's a very prolonged emergency, of course, imposed due to a medical health problem, that is tuberculosis. And today, still we are facing a lot of morbidity and mortality. Every fourth TB patient is Indian, number one. And of course, we are also facing a mortality, significant mortality, 1,000 people dying every day due to tuberculosis. Now, the question is that with this update in tuberculosis, how to combat, and of course, the very important landmark, I would say, very auspicious, very ambitious day that to be recorded in the history of tuberculosis in India, that is 13th March 2018, when Prime Minister declared that a very fascinating and of course the end of the deadline for the ending tuberculosis, for elimination of tuberculosis, that is 2025. So we are in 2021, still facing the problem of COVID, and people are speculating that COVID has created such an environment that the management of other diseases that has suffered in 2020. And people are speculating, although I'm against that opinion, that people are facing that in 2020 morbidity and mortality has increased in India as well as in globe. But I am personally against this opinion. I think that out of the 12 months in 2020, there were 3 months lockdown, and during lockdown, TB patient also and everybody, they were inside the home. And after that also, everybody was wearing the mask. So rather, lockdown and mask use has decrease the transmission of TB. That is my personalized perspective. Of course, the time will tell when the data of the mortality will come for 2020. The only thing is that notification has come, and notification is, of course, low. That is true. But notification low, that does not mean anything, because mortality is more important. And my dear friend, we should remember that elimination of TB doesn't mean that morbidity will go down. We will not have any single case after 2025. The elimination by 2025 clearly defines that we should have zero mortality. So main target is to make zero mortality 25. It is not the cases zero. That we have to understand. So we have to target for the mortality. So if the mortality in 2029, the data yet to be declared. So if the mortality has gone down in 2020, probably mask will be a very important weapon against the fight against tuberculosis. And if you want to really know the double trouble, COVID and TB, you just read my article today in Dainik Jagran. Dainik Jagran, we should be proud of our Hindi language. That Dainik Jagran is the newspaper which is most widely circulated newspaper, not of only India. It is of world. Yes, if you compare the Washington Post or the Wall Street Journal, then it has surpassed, the circulation has surpassed these important, of course, newspapers. And now number one newspaper, which is most widely circulated among the people, is the Dainik Jagran, that is Hindi, published from 11 states of the country. And you can read my article, The Double Trouble of Corona and COVID, on health column, which is published in all 11 states of the country. So by one mask, simple mask, we have to propagate the mask. We can fight two important diseases, TB as well as COVID. This can be a very vibrant, dynamic, and important tool and weapon for fighting against tuberculosis, number one. Number two, we have to make this public movement. Dr. Pyali is there. She has made the public movement. She has observed. She is the, of course, very dynamic witness of the pulse polio movement. And that's how we declared country polio free in 2014. So similarly, I think by the, of course, experience of Dr. Santosh Gupta, who has worked around 14 years in WHO and pulse polio program. Madam has worked. Dr. Prerna Kapoor is still working as a nodal officer in the SGPGI for tuberculosis. And so we have to create this scene, we have to create the scenario like pulse polio movement, like the TB movement. And yesterday we started a very innovation. I want to share with you what yesterday the Department of Respiratory Medicine and Dr. Surikant has done innovation in this regard. Last day, Mr. Kumar Keshav, of course, everybody knows he's a metroman of Uttar Pradesh, like Sridharan is the metroman of all India. So like Mr. Kumar Keshav is the metroman of Uttar Pradesh. So he's the everything for the UP Metro Railway Corporation. So UPMRC organized yesterday a program, and Department of Respiratory Medicine and KGMU started a joint venture with Lucknow Metro. What is that? I want to share with you that today onwards, oh, pamphlet है क्या यहाँ? तो टीवी वाला पैम्पलेट जो सब मरीजों को बंटवाया है, अरे यहीं रखा है, अंदर से ले लो, शोभा से ले लो. So yesterday we decided to अच्छा ठीक स्टेटमेंट दे दिया, मोहर लगा दिए यार, हम तुमसे कहा था मोहर लगवा के. So सॉरी बड़ा मुश्किल है. चलो कोई ऐसी बात नहीं हो रही जो डॉक्टर के अग्रवाल साहब के साथ हुई थी, मेरे साथ ऐसी नहीं हो रही. अभी मैंने एयर फोर्स पे ला दिया, फ्लाइट मोड का, वाइफ का फोन नहीं आएगा, इसलिए हम डर नहीं लग रहा. So हाँ, so this is the pamphlet. You can see, I think you cannot see the language of the pamphlet, the matter of the content of the pamphlet, but you can very well visualize the metro. You can very well visualize the metro. Yes, metro
Yes.
दिख रही madam? Yes. So this is the joint venture between Respiratory Medicine Department and Metro. So we have developed the this pamphlet. This is being distributed from today onwards to all passengers of Metro. This is one-page pamphlet indicating the morbidity, mortality, symptoms, diagnosis, and where are the various centers, KGMU and SGPGI and like Ram Manohar Lohia Institute, Civil Hospital. So all centers, important centers given, and of course one helpline number, and of course dot up now TV Dur Bhagao, and source is Respiratory Medicine Vibhag KGMU Lucknow. So they have acknowledged us that this is the source, of course, authentic source for this information is Department of Respiratory. And the second thing, I think, which will be implemented soon, yesterday I resolved, this was also resolved unanimously in that meeting, that if you go inside the metro, I think most of us, they have, of course, traveled through metro. अरे बैटरी कहाँ से लो आ गई बे, चार्ज को नहीं रखते हैं. So इधर ले जा. So the if you see inside the metro, there is a space like a TV, and there is a e-advertisement. So in e-advertisement, they will also show the advertisement regarding the TB, of course, as a health awareness, in which they will also show the Amitabh Bachchan, our brand ambassador, showing 2 हफ्ते से ज़्यादा खांसी है तो 2 बलगम की जांच करो, like this. So this kind of venture we have. And one more thing, I was also invited to deliver a lecture on occasion of World TB Day at the Badshah Nagar Railway Hospital. So it's from yesterday onwards, I am working on the railways, because most of us in India, most of the Indians, they travel through the railway. So रेलवे में जाते हैं, पूरी सब्जी भी उसी में बैठ के खाते हैं, और प्लेइंग कार्ड्स भी उसी में खेलते हैं, और गपशप भी करते हैं. पॉलिटिक्स वहीं से, जब देश सरकारें बनती हैं, बिगड़ती हैं, गिरती हैं, सब कुछ वहीं होता है, रेलवे में ही होता है. So that's a very interesting story of railway. So when I delivered the lecture, then I asked the Madam DRM, Madam Agnotri, of course Monica Agnotri, who is the divisional railway manager for the Lucknow Railway. So I said that I'm proposing here that same kind of thing can be done in railways also. At least we can have the poster, some poster awareness poster at the platform, and of course on the bogies, different bogies of railway. So she promised that she will forward this proposal, because the permission from the Central Railway Ministry should be taken for that. So if this gets, so this will be a big boost for the awareness program. So I think Sanjay Gandhi PGI, KGM, everybody, Dr. Prerna, Dr. Santosh Gupta, and Dr. Pyali Bhattacharya, everybody has to develop such innovative ideas, without which the target of Prime Minister 2025 is not possible. So I think we should do every effort. For example, we involve Amitabh Bachchan, we involve Amir Khan, we involve all Maulanas, all Panditji, all everything for the mass movement of the Pulse Polio program. Similarly, we have to involve not only one Amitabh Bachchan for 130 crore population, but a single mohalla. I mean, every mohalla, every city, every town, every village should have one Amitabh Bachchan. So, of course, Pyali ji can be the brand ambassador for the pediatric TB population of the Uttar Pradesh. She is very much popular among the pediatrics population, pediatrics fraternity, as well as the immunization program, government, governor house. She is popular everywhere. Uttar Pradesh, chief minister, everybody. So I think we can utilize her face as a brand ambassador for the elimination of. She should say, देखिए बच्चा लोग तो टीबी फैलाता नहीं है, हम लोग बड़े लोग टीबी को फैलाता है, तो बड़े लोगों से बच्चों की जो चेन है वो काट दीजिए, बच्चे तो अपने ही टीबी फ्री हो जाएंगे, वो तो किसी को फैलाते नहीं है. दैट इज द यूनिक सिचुएशन ऑफ द पीडियाट्रिक टीबी पॉपुलेशन कि हम लोग एडल्ट लोग, यंग लोग उनको टीबी फैला रहे हैं, बच्चे लोग किसी को टीबी नहीं फैला रहे हैं. सो बच्चे इनोसेंट हैं एज फॉर द ट्यूबरकुलोसिस स्प्रेड इज कंसर्न. So I think that's a very unique feature of the pediatric tuberculosis, and that we have to acknowledge, and then we have to utilize for at least first of all on priority basis we can make TB free in the pediatric population. That can be our one target. Similarly for females also, female genital tuberculosis, the females, Madam Prerna, they are not spreading the disease. So I think the second population can be that we can declare they are females that primary infertility now treated, diagnosed, treated, everything. Now there is no female suffering from female genital tuberculosis. And third group is the extrapulmonary tuberculosis. Again, that is non-infectious. So I think we should priority basis diagnose. And of course, we cannot eliminate tuberculosis by correcting the immunity factors. And most important immunity factor, madam will agree, is the malnutrition. अभी 2 दिन पहले ही मैडम ने बताया था, पतलू राम भी मेलनरिस्ट है, मोटू राम भी. बड़ा अच्छा डायलॉग, मैंने तो रट लिया, मैं 10 बार सुना चुका हूँ. मेरी बिटिया हंसती है, पापा थोड़े, मैंने कहा क्या करूं, मैं ड्राइंग रूम में निकला, पतलू राम भी मोटू राम. कह रहे पापा क्या बड़बड़ा रहे हो, पतलू राम मोटू राम, कुछ मतलब जरूरत हो तो चलो दिखा लाएं आपको वहां सड़क के उस पार मतलब सेक्रेटरी डिपार्टमेंट. मैंने कहा नहीं ऐसी जरूरत नहीं है अभी. तो मैं मैडम का डायलॉग रट रहा था, इतना अच्छा मुझे लगा 2 दिन पहले कि पतलू राम को भी टीबी हो सकती है, मोटू राम को भी हो सकती है. हमारे यहाँ न्यूट्रिशन का कॉन्सेप्ट है, जो मोटा है मतलब बहुत हेल्दी है. सो दिस इज नॉट द करेक्ट कॉन्सेप्ट. Even overnutrition and the fatty children, they can be. So we have to propagate whether you want to, if you want to become burger child, you will not be an immune child and you are more vulnerable for so many diseases, including TB. So I'm not against burger, but we are against this culture of burger. अरे 1 महीने में 1 बर्गर खा लिया तो कोई फर्क नहीं, लेकिन 1 महीने में 1 रोटी खाई तो बहुत फर्क पड़ जाएगा. रोटी रोज खाओ, बर्गर 1 दिन खाओ, कुछ नहीं फर्क पड़ेगा, लेकिन बर्गर रोज खाओ, रोटी 1 दिन खाओ तो फर्क बहुत पड़ जाएगा. सो इम्यूनिटी, ऑफ कोर्स इम्यूनिटी आप सब करिए. अब ये ऐसा नहीं, इसके तो गुलाम हम भी हैं, हमें भी अच्छा लगता है. आज हमने भी सुबह 1 समोसा खा लिया, क्या करें. सो रेलवे में गए तो उनका समोसा अच्छा लगा, टेम्पटेड था, बड़ा ऑयल कम लगा तो मैंने भी खा लिया. सो such kind of things. So we have to correct the malnutrition first. You cannot think of even eliminating tuberculosis without correction of nutrition, number 1. You cannot think of the correction of diabetics. So we have to control smoothly diabetics. You cannot eliminate tuberculosis. Similarly, if 12 crore smokers are there in this country, so can you imagine without stopping smoking, you can eliminate TB? No, you cannot. And such type of things, they should be, I think SGPGI should take the lead. I think we can draft that you cannot eliminate TB in this country until ... Malnutrition is 1, diabetes is 2, smoking is 3, air pollution is 4. So many factors. And of course, we have to continue all preventive measures which we have learned during the COVID times. Namaste is a very good practice. Hand wash is a very good practice. Mask is a very good testing. Distancing is a very good. All 4 points, they are very good. Not only the prevention of chain of COVID, but also the preventing the chain of TB, pneumonia, and so many infections. Sorry, ma'am. मैं तो कुछ ज्यादा ही बोल गया. अभी वहां दोपहर में बोल के आया था रेलवे में, तो मैंने वही भड़ास निकाल ली अपनी. मुझसे क्वेश्चन पूछ रहे थे लोग. So thank you very much for giving this opportunity. Over to you.
Thank you, Dr. Suryakant. As usual, it's fun listening to you. याद नहीं रहता है कि समय कितना रखा था और कितना हो गया है, क्योंकि आप इतना अच्छा बोलते हैं, हिंदी अंग्रेजी दोनों में आप दिग्गज हैं. And actually I would like to say कि India has Amitabh Bachchan and UP has you and NTEP has you. आप NTEP के और COVID के अमिताभ बच्चन हैं, and you are doing great work actually on both fronts. और awareness के लिए your, and the one point that you made is that the other factors which are associated with TB, they also have to be, which will promote the infection from spreading, have to be prevented. That is one thing. Notifications of course have to go up, and हमारा फर्ज वही बनता है, awareness and more awareness. If we create awareness, अगर हम सब अपने आस पड़ोस में कोशिश करें कि जिसको भी टीबी हो उसको जल्दी से जल्दी डायग्नोसिस और इलाज हो, so we are preventing new patients from getting created. I think that's a very, very important take home point. So thank you, Dr. Suryakant. I know that you have a very, very busy...
Madam, it's going live. I saw that it's going on live on YouTube. So later on, you can send the link so that I can forward to my resident and other colleagues the whole
Absolutely, Bilkul. Thank you so much. Thank you so much for being present. I know it's a very, very busy day for you. In fact, the last 1 week has been very busy for you. We have been seeing all your programs. That it's been a very busy time. Thank you so much.
Thank you, ma'am.
We go on to our next speaker, Dr. UC Ghoshal. Dr. Uday Ghoshal is professor of... Dr. Ghoshal, am I audible to you?
Yeah, you are audible.
Okay, so Dr. Ghoshal is professor of gastroenterology in SGPGI. He is a stalwart in the field of gastroenterology. And इनके बारे में मैं हमेशा सोचती हूँ, जब इनका मैं CV पढ़ती हूँ तो दिल घबरा सा जाता है कि इतना बढ़िया CV, लेकिन इनसे बात करती हूँ तो मजा आ जाता है, because he is such a dear friend. Despite being such a knowledgeable person, he is also the faculty in charge research of SGPGI. He has lots and lots of publications, more than 320 publications, more than 11,000 citations. He has brought SGPGI on the world stage because he has been recognized as one of the best scientists and researchers in the world. Yet he remains a very good speaker, a very knowledgeable person, and like I said, a dear friend. So Dr. Ghoshal is going to talk about GI tuberculosis. Over to you, Dr. Ghoshal.
Thank you, Dr. Piali and Dr. Prerna, and also all the organizers who gave me this opportunity to speak on this important topic. So what I did is I thought, instead of taking all the aspects of GI tuberculosis, which is difficult in short time, it is better to take a few current issues which really trouble us as gastroenterologists. Now, as you told already, the tuberculosis can affect any part of the body. This is so true when we talk about GI tract. And obviously, clinical presentation of the patient depend on what is the site of involvement. Obviously, the major site of involvement is ileocecal, and therefore these patients present with recurrent subacute intestinal obstruction, sometimes diarrhea, rarely GI bleed. And because of this presentation, that is recurrent subacute intestinal obstruction, alteration of the bowel habit, some GI bleed, these patients really mimic Crohn's disease, and we have real difficulty because earlier things were easy because it was thought that Crohn's disease is uncommon in India. So therefore, in earlier days, people or gastroenterologists would diagnose every such patient as tuberculosis, but we really realize many of them are not tuberculosis, but Crohn's. So this is an important topic that I'll discuss. How do you really differentiate between Crohn's and tuberculosis? We have seen patients who present with dysphagia because of esophageal involvement. We have seen patients who presented with gastric outlet obstruction because of gastroduodenal involvement, even anorectal involvement, which is uncommon, but sometimes patient comes with anorectal involvement like a tumor in the rectum. Rare patient comes with pancreatobiliary and hepatic involvement, And I'm not going to talk about ascites due to peritoneal involvement, which is a common presentation in gastroenterology. Now, let me talk about Crohn's disease. The problem of those patients who come with ileocecal involvement to a gastroenterologist, the problem is if I say this patient may have tuberculosis, obviously I'll give him anti-tubercular therapy. On the other hand, if I think this has Crohn's disease, then I'll give corticosteroid, infliximab, and other immunosuppressive agent. And these are really dangerous. That a TB patient get immunosuppressive agent, and this can really kill the patient. So this is an important dilemma that I would like to discuss. Let us look at this patient. This is a colonoscopic finding, and you can see there are ileocecal ulceration, some stricture formation. As a gastroenterologist, what is the diagnosis? As a physician, what is the diagnosis? As a surgeon, what is the diagnosis? No, we can't say it is tuberculosis. We can't say it is Crohn's. It can be both. Now then, how do we differentiate? Can we differentiate based on the clinical presentation? Can we differentiate based on the radiological presentation, colonoscopic finding? Best would be if we got acid-fast bacillus. But let me tell you, you get acid-fast bacillus very luckily. About 2 to 6% patient will show acid-fast bacillus in the biopsy from the ileocecal area, because this is a typical paucibacillary disease compared to pulmonary disease, which is not paucibacillary, because AFB or tubercle bacillus need oxygen for growth. So this is paucibacillary disease because GI tract is quite anaerobic. Can you do serological test? Absolutely useless. Anti-TB serology has been banned by WHO in the endemic area, but unfortunately still we see reports of patients who are suffering from chronic disease. Somebody does an anti-TB serology test and start him on anti-tubercular therapy. Can you do TB PCR? Yes. Can we give empirical ATT? Yes, we'll end up doing that, and we'll talk about future too. This is all about clinical presentation. Actually, scientists tried to say, is there a probability of one symptom being more likely tuberculosis than another symptom, which may be more likely Crohn's disease? And this is a very mathematical technology that we call meta-analysis. So meta-analysis showed that relative risk of something being TB or odds ratio of something being TB than Crohn's is based on the clinical presentation of the patient. But let me tell you, it doesn't help in a given patient. It is good to talk about odds ratio, that is probability of TB over Crohn's, but in a given patient, it is difficult. Now, let me share with you a patient, 18-year-old male. He came to us with progressive distension for 1.5 months, weight loss 12 kg, no vomiting, bowel alteration. Examination normal, except his body mass index was 19, which is low. We found a lump in the abdomen, 15 into 15 centimeter, firm bossylated. There was no respiratory movement to this lump. There was no fall in the knee elbow position. There were palpable borborygmi. Percussion note was tympanic, and bowel sounds were increased. Now, every investigation was normal, except ESR being somewhat raised, 31. Mantoux 12 millimeter doesn't mean anything in India because we can be all Mantoux positive. It basically means we have immunity towards tuberculosis. We are exposed sometime to tuberculosis. HIV serology negative, stool occult blood negative, chest X-ray normal. Remember one thing, GI tuberculosis patient, only 15 to 20% shows chest X-ray abnormality. So this is what is expected. Ultrasound showed mild splenomegaly, moderate ascites. Colonoscopy, mucosa, lumen normal up to ascending colon. Now this is the chest abdominal X-ray and CT scan. All the bowel loops are matted. You can see there. There is mesenteric thickening. There is bowel wall thickening, some interloop fluid. Ultrasound guided FNA from mesenteric node showed granuloma with epithelioid histocytes, and Gill-Nielsen stain was positive. We are lucky. That rarely happens. So he improved with 4-drug ATT. Look at this patient, 65-year-old female, pain in anus, increasing during defecation for 2 months, weight loss 5 kg, no GI bleed, known diabetes and hypertensive for 15 years, everything normal except low hemoglobin and some low albumin. This is the colonoscopy. What colonoscopy showed is like a mass, something like a polyp. One would say this is colon cancer or rectal cancer. So our differential diagnosis, yes, colonic cancer, lymphoma, inflammatory bowel disease, and infective condition. Real-time PCR for M tuberculosis was positive. So we are lucky. Microscopy and tuberculosis MER was positive, and she had a predisposing condition, diabetes. HIV was negative, and she responded to ATT. So therefore, I told you, only 2 to 6%, at most 8 to 10% patients with GI tuberculosis will show AFB. So we have to rely on indirect test or maybe molecular test, for example, TB PCR. Second is there is a recent technology which is called GeneXpert, which not only gives you mycobacterial DNA, but also give you the molecular or DNA-based marker for rifampicin resistance. And this is one of our study where we took 31 patients with tuberculosis. And then we did endoscopic ultrasound guided FNA of the lymph node. And what we found is if you look for TB smear or culture, often you get negative. For example, here we got very often smear and culture for TB from the lymph node FNAC was negative, but GeneXpert was usually positive. So what happens is you can only culture an acid-fast bacillus, which is live. If it is dead, you can't culture it. You can also see on the staining acid-fast bacillus, provided it has that waxy wall. That means it has a wall which is waxy. That's why it is acid-fast. Many a time when pathologists do the processing, that waxy wall is removed and therefore it is no more acid-fast and it may not be seen, but GeneXpert detected it with 97% frequency. So what we'll end up doing is we just go by clinical probability. We look at previous TB contact, HIV positive test for TB, and then we give ATT. Otherwise, what we do is that we give empirical anti-tubercular therapy, and 2 months later, if the patient responded to anti-tubercular therapy, it is likely TB. But if he did not respond to anti-tubercular therapy, it may turn out to be Crohn's. Another issue that I want to highlight here, this is very, very important. This was a study which was actually sponsored by revised National Tuberculosis Control Program, Government of India, from the center through All India Institute of Medical Science. What they wanted to look at is the cost saving, because GI tuberculosis, typically it was said that you have to give 9-month or 12-month anti-tubercular therapy. And obviously all these therapies are free, as you heard from my previous speakers. So therefore, government or taxpayer is actually giving this money. So if government or taxpayer is giving this money, what happens is they will see, is it worth giving for 9 months? So they actually wanted to do a trial, 6 months versus 9 months. We did a 2-year follow-up, 6 months versus 9 months, 200 patient randomized, and we found 6 months is as good. So therefore, this is good because there is a 3-month cost saving. So what I would say is that this is a very good initiative from Dr. Piali, Dr. Prerna Kapoor. I think would like to collaborate with you more so that some of these patients who are not otherwise notified will like to notify, will like to work together for tackling this TB menace. So I'm sorry, maybe because of our busy schedule, many a time we did not actually meet each other, but maybe from now, because we got this opportunity, we'll work together. Thank you so much.
Thank you, Dr. Ghoshal. As usual, you do.
डॉक्टर घोषाल को एक सजेशन है in case of his busy schedule, if he is unable to notify, he can just ask somebody to keep a copy of the note down on the paper. We'll do the rest. We'll send somebody over.
Thank you.
Absolutely. Or give me a call, Dr. Ghoshal, and the rest I'll do. Yeah, you can just WhatsApp to me or call me. And thank you for this very informative lecture. As usual, whenever we listen to you, you do more than justice to the topic which you take up. That was the thing that you actually illustrated with case studies. That is the best manner in which you can bring out the difference between what is TB, what are the complexities of diagnosing GI tuberculosis, and how do you go forward in those cases which are difficult to diagnose. Thank you so much. Because of paucity of time, we had a short lecture. I think in the course of this year, sometime we can have a whole session on GI TB with you and with some other people from the gastroenterology. Thank you so much. Now we welcome our next speaker, our nodal officer of General Hospital, Dr. Piyali Bhattacharya, and of course, my colleague for more than 20 years and a real dear friend and a very passionate pediatrician. She is going to talk about pediatric TB. She has also been she's had a long association with the NTP, the TB elimination program, even when it was back then when it was RNTCP. She's the one who started the RNTCP program actually in SGPGI. So over to Dr. Piyali for her talk on pediatric TB. Everybody knows Dr. Piyali. I really don't need to introduce her. The slide of her resume, I've already put her, and suffice it to say that she needs a separate room for all her trophies. She has now amassed so many prizes and trophies, and she's a very important person in tuberculosis in pediatrics in UP and in India. So over to Dr. Piyali.
Thank you, Prerna, for those kind words. If you stop sharing, I'll share my screen.
Yes. There.
So can you see the screen now? So the clock is ticking. That's the theme for World TB Day 2021. It means that the clock is actually, it is like रेत हमारे हाथ से फिसला जा रहा है, and that is why the importance of notifying TB again and again, as STO sir was saying. Statistics of pediatric TB. Oh, this is a case. Thank you, Vimal Paliwal. This is your case which you had sent to me for a referral. This is a child of TBM which came from neurology to me. And statistics says that in 2019, a total of 1,51,286 pediatric patients, they were notified in India. This included new and relapsed pediatric TB patients. So COVID played a spoiler and we didn't have so many of them. Needless to say that 31% of the global burden is being borne by India, and 10% of those cases coming under the program NTEP are children under the 14 years of age. Another thing is that the non-extrapulmonary TB forms a very large chunk, and MDR TB is being underestimated and underjudged. So having said that, with such a large number of pediatric TB patients, zero death by TB is a dream, because without ignoring these pediatric patients, we cannot go ahead in zero death by TB. Now, when we say pediatric TB, it is a big challenge for the pediatrician to diagnose a PDTB. Say a confirmatory test, because the direct smear and microscopy may be negative, may be positive. A tuberculin skin test may not be confirmative. There may be a microfocus in the lung which may not be discernible at all. And because compliance is very, very poor, the MDR TB is underestimated, the child may not be picked up at all. So the clinical spectrum, when we say of pediatric TB, other than the intrathoracic TB, we have a lot of extrathoracic TB. In fact, 40% of that TB is extrathoracic that we get. So we are collaborating today with all of you because pediatric TB, I think everyone has one pediatric TB, be it whatever part of the body it occupies. So when we talk, has something changed? That is the thing that we need to know. So there are new definitions. With the stigma of TB suspect, now we are now saying it is presumptive TB. There's a change in the diagnostic algorithm, there's a change in the treatment approach, there's a change in the follow-up as well, and changes in management of the drug resistant. So what is presumptive TB? When we say presumptive, remember it is a persistent fever or cough for greater than 2 weeks, a loss of weight 5% or more, and no weight gain, either of these two things in the past 3 months, and or history of contact with an infectious TB cases. In fact, in a symptomatic child, contact with a person with any form of TB for the last 2 years may be significant. Similarly, we have presumptive extrapulmonary, which is along with the local symptoms, it is there with the constitutional symptoms as well, and we have a presumptive drug-resistant TB. So all those we used to call TB suspects, and in fact they said कि ये suspect क्या होता है, आप लोग हमको जेल में डालोगे क्या, suspect लिखते हो तो मतलब जुर्म करने वालों के साथ होता है. So WHO has now made it presumptive tuberculosis. Now in the drug therapy we were giving 3 drugs and we were omitting ethambutol because we thought that it was causing a lot of toxicity. However, now we have a 4-drug regime, HRZD, plus a 3-drug regime where pyrazinamide is omitted. Now the duration has been increased to 9 to 12 months for bone and CNS TB. And let us see what further changes. So the intermittent therapy has now become daily therapy. It is not that the intermittent drug therapy was not working, but people were missing out on doses. So since they were missing out on doses, it was actually, if in a month if you're giving intermittent, it is just about 13 doses, and missing 2 or 3 doses means there's an unacceptably high reduction in the total number of drug dosages. So what was happening was people were missing out doses and there was a serious threat of treatment failure. So we actually increased the drug doses by creating 6 weight bands. The pediatric kit now has 6 weight bands, and in 2019 this adult weight band was also attached to the pediatric weight band, where after 16 to 24 kgs we have 25 to 34 kgs, as Dr. Suryakant was saying, motu ke saath patlu, patlu ke saath motu. So for the obese children, we now go up to 50 to 64 and greater than 75, where we add adult doses to them. So it's very easy now. You have a pack of HRZ and you add an ethambutol to it in the initial phase. And after the intensive phase, you have the continuation phase where you have a blister pack where it is HRZ. And the equation is also very easy, where it is 1 tablet, 2 tablet, 3 tablet, 4 tablet, followed by addition of the adult tablets. Other medications which have been said now is pyridoxine supplementation has been added as a regime to the INH therapy, the HRZD therapy. All children with now steroids was being used very, very loosely, and now we have specific sort of recommendations for use of steroid. Do not use it loosely. So all children with TBM will be treated with adjuvant steroids regardless of the disease severity. So either prednisolone or dexamethasone for a 4-week time and then tapered over for the next 4 weeks. What are the changes in follow-up? We used to just leave them, let them go. But now it is a clinical monthly follow-up, not all the time doing sputums and chests and CBNATs and things of that kind. It's just a clinical follow-up every month. Sputum only twice in the whole course of therapy, and a follow-up of 2 years, evaluation at 12 months, 18 months, and 24 months after completion of therapy. So the algorithm therefore has changed also because CBNAT has come in and X-ray chest has been given priority over here. And sputum smear, again, the numbers have been decreased to just 2. So if it is sputum smear positive, it's a bacteriologically confirmed TB. The child does not have to go back and come back again for a third sample or a second sample. The two samples can be given even at a 2 hours difference. And X-ray test has now been made mandatory. So X-ray test, if it is highly suggestive, go for CBNAT. If it is not so highly suggestive or the suspects are just suspect shadows, then you go for a course of antibiotics. If it is normal and the skin test is positive, you need to evaluate for extrapulmonary tuberculosis. So the maximum scoop, as I said, is from lymph node tuberculosis. So the algorithm for lymph node tuberculosis has also changed. So we have an enlarged matted cold abscess with or without discharging sinus. We do a smear examination, a CBNAT. As I said, CBNAT has been given a lot of importance in the newer regimen. Except for blood and urine and stool, possibly everything that we get, a lymph node aspirate, a skin biopsy, or whatever we get, tissues are very, very amenable to a CBNAT and positivity. So lymph node enlargements where we are suspicious, remember we can give a course of antibiotics, but please do not try to use quinolones or linezolid. Leave them for the drug resistant cases. The newer two drugs which has come in, everybody knows, bedaquiline is not yet approved for children, but delaminid is now approved. This is one of the first drugs which has come in approved for children for MDR TB, and 6 to 17 months it's available even with us in SGPGI in the dot center which runs from the General Hospital. So thank you very much for a patient hearing, and I rest here.
Thank you, Dr. Pyali. As usual, you were very lucid, very eloquent, and also there's a lot of echoing. You were really, really eloquent. I know that pediatric TB is your forte and also your passion. And we are all here, gathered here today to talk about awareness of TB. And you've always been doing that for a long, long time. And at the same time, correct diagnosis and correct treatment. Early diagnosis, correct treatment, prevention, the breaking of the transmission chain of infection is so very important. You and I talk about this so often, and your lecture was short but very informative. Thank you so much. Is Dr. Paliwal here? Yes, I can see Dr. Paliwal. We'll go on to our next speaker now, Dr. Vimal Paliwal. Thank you, Dr. Pyali. We go on to Dr. Paliwal now. Welcome, Dr. Paliwal. We know what
Thank you, ma'am. Thank you
you
so much.
had during COVID times. So thank you so much for sparing time today to talk about neurological TB. And Dr. Paliwal is a professor in the Department of Neurology in SGPGIMS, and he has a lot of publications to his credit, though he looks extremely young, and which is thanks to his, my God, am I audible?
Yes,
am
ma'am.
audible, I think.
Please continue.
Dr. Paliwal looks really, really young, which is thanks to his fitness spree. But, well, he is actually a very learned person in his field. His clinical interests are tropical neurology, headache, and epilepsy. And he's going to talk to us today about interesting aspects of neurological TB. Neurological TB always remains a slightly more difficult type of TB to diagnose and also to treat. There are always questions in our minds as to for how long to treat, how to follow up, how to even know that the patient is improving, because these things are not as clear-cut as they are in pulmonary or some other extrapulmonary TBs. So over to Dr. Paliwal for his lecture.
Thank you, ma'am. Am I audible, ma'am?
Yes, Dr. Paliwal, you are audible. Please carry on.
Ma'am, if you can stop sharing the screen, then I will be able to share my screen. I hope my screen is visible.
Please continue, Dr. Paliwal.
Yes, sir, it's visible.
Okay. I must congratulate Dr. Pyali and Dr. Prerna, Dr. Rama for organizing this very interesting format of CME. After a very long time, I am participating in a CME where the lectures are very short and they are multiple. So I always like this format, 10 minutes talk. Actually, it is more difficult to prepare a 10-minute talk than to prepare a 30-minute talk. And second, that you get an opportunity to listen to many participants and to learn from them. So it is a great opportunity. Thank you again for inviting me for this talk. So I'll be talking about the challenges that we face in diagnosing and in managing the CNS tuberculosis. So I'll start with this case. She is a 23-year-old female with tuberculous meningitis and multiple tuberculomas. I took the photograph of the one which is present in the right CP angle area. The first MR was in 2016. At the time, she was started on 4-drug ATT. The clinical improvement was reciprocated with the radiological improvement. And by 2019, the tuberculomas had disappeared. And there you can see slight hypointensity suggestive of some sort of calcification. However, she is admitted only 5 days back with a 20-day history of worsening headache. And this time we repeated her MR and it again showed the appearance of tuberculomas at the same place. And it is enhancing here despite the fact that the tuberculomas have calcified. So this is a picture that we often see in our clinical practice, and it confuses, like everyone, we also are confused that what went wrong in such patients. So what was the reason of disease recurrence? Whether it was an incorrect diagnosis. Now you know that the CSF yield of AFB is very, very low. So it is very difficult to diagnose CNS tuberculosis. And majorly we rely on the clinical features and radiology. Drug resistance is increasing. Pulmonary tuberculosis 20 to 25%, and around 1/3 of this is the CNS tuberculosis resistance, which is reported in the literature. And the other thing is that the CSF penetration of the drugs is also very poor. So it is very difficult sometimes to know whether the patient has been adequately treated with ATT or not. Third, there are many times paradoxical reactions. Paradoxical reactions are when the patient is improving, but CSF or radiology shows a recurrence of disease. So whether in this particular case we are dealing with a paradoxical reaction, it is a recurrence of the disease is still not known. And the most important part is how much treatment should be given, what is the adequate duration, and what is the adequate number of anti-tubercular treatment that is still not known in case of a CNS tuberculosis patient. So the spectrum of CNS tuberculosis is actually very wide. For cranial tuberculosis, it is tuberculous meningitis, tuberculous encephalopathy, which was reported around 50-60 years back, but we seldom see these cases now. Then tubercular abscess and tuberculomas. And in spine, it's POTS spine, POTS paraplegia, non-osseous spinal tuberculomas, and spinal meningitis. So for all kind of CNS tuberculosis, whether it is the brain or the spinal cord, the questions that the initial patient actually aroused are same for all of them. So what we do for diagnosis is that we do not rely on a single thing because there are no such criteria. So though there are many diagnostic criteria, but if you study all the diagnostic criteria, they talk of totality or taking into consideration many things. So there can be clinical features like fever, headache, weight loss, vomiting, meningeal signs, paraparesis, spinal tenderness and gibbous, presence of a past history of tuberculosis which may be adequately or inadequately treated, contact with the patient of tuberculosis, especially if there is a family member affected with tuberculosis. If a patient has a tuberculosis elsewhere like pulmonary, pleural, abdominal or lymph node TB. CSF examination becomes very, very important, though the yield of AFB from the CSF is very, very low. It is low to extent that we see a CSF AFB positive only once or twice in a year, and culture may be less than that. So we rely on high protein, low sugar lymphocytic pleocytosis. And now with the advent of gene experts, some positivity we do get, but it is still very low. And we also rely much on brain MR, the presence of basal exudates, optochiasmatic arachnoiditis, tuberculomas, paradiscal involvement in case of spine, presence of soft tissue changes in the paravertebral muscles. and presence of spinal raccoonitis. They all are features which suggest that the patient might be suffering from a spinal or brain tuberculosis. So, but there are issues and limitations of relying on every one of these. Like, for example, relying on clinical features alone is also not free of faults. So this was one study, very large study over a period of 30 years. And what they found was that the prodromal symptoms of tuberculosis was like only fever was present in only 13%, vomiting 25%, headache 28%, meningismus 2%. So many of the residents, if they look at this slide, they won't believe, because all the patients of tuberculosis that we see in our wards, all of them will have fever, vomitings, headaches, and meningismus. Now the issue is that by the time a patient reaches a tertiary care center, he has actually deteriorated from stage 1 to stage 3 CNS tuberculosis. And by that time, all the features have come. So if an expert goes to a primary care area and see the patients, he'll find almost the similar kind of prevalence of the cardinal symptoms. So these patients do not take drug or not diagnosed in the time, and they over a period of time develop the severe disease. Second thing is that we generally believe that tuberculous meningitis or spinal or cranial tuberculosis is a chronic disease, which is not, because majority of the patient will have acute presence of symptoms. In this case, 55% of the patient had symptoms of less than 2 weeks, and only 36% of all these patients could be diagnosed with tuberculous meningitis. The second issue is of CSF gene expert yield. Now the literature says that the sensitivity of the gene expert in the CSF is around 79.5%. But the issue is they take culture as gold standard, and the culture positivity is already very low. Sensitivity reduces to 55% when we take the clinical gold standard, the clinical case. Now it has a negative predictive value of 84%, but having said that, if we see in clinical practice, the positivity rate for sensitivity especially is much lower than 55%. And I think that all the tuberculosis patients that we see, especially TB meningitis, we don't see more than 1/3 of them having a CSF gene expert positive yield. So it is again a very big challenge. And we, in this era, also have to rely on clinical and radiological features, which are not free from issues. So there are many differential diagnoses of all the MRI findings that I enumerated. So this can be fungal meningitis, bacterial meningitis. Now fungal meningitis can produce basal exudates. It is always confused with neurocysticercosis, and we tend to see for the eccentric nodule or the scolex in all the patients, which is sometimes very difficult to see. And many of the neurocysticercosis patients actually are treated like multiple tuberculomas. Then the carcinomatous meningitis is again a very close differential diagnosis, where the CSF picture is also very much similar to that of tuberculous meningitis. Spinal and brain metastatic disease again behaves like multiple spinal or brain tuberculomas. Port spine is very similar to brucellosis. Then there are immune-mediated brain and spinal cord diseases which mimics CNS and the cord tuberculosis. So there are many differentials of MRI findings of cranial and spinal tuberculosis. Now the issue with drugs also. So there are new drugs which have come up, and the resistant tuberculosis, especially the pulmonary tuberculosis, now have a treatment which is based on delaminate based treatments, bedaquiline and delaminate. But the issue is that these newer drugs, they hardly go into CSF. So there is low penetrability into the CSF. Similar is for many other drugs, like for example, levofloxacin, moxifloxacin, they have a good penetration, but we seldom use them because many of these patients with CNS tuberculosis will be having seizures, and these are all seizurogenic drugs. So we have various limitations in using anti-tubercular drugs also, especially if we have a case of a resistant tuberculosis. Then there is the issue of duration of ATT. Now, as the first case you saw, she received ATT for nearly 2 years and had a recurrence. But what the literature says, as Dr. Ghoshal also said in his study, that the short course treatment is as good as the long course treatment. But most of the people who are treating CNS tuberculosis won't agree. I myself was a part of the index guideline committee which created guidelines for extrapulmonary tuberculosis in India. And there was a lot of hue and cry in the committee also, and people did not accept this, the Cochrane database, and they actually were satisfied when we thought of increasing the duration of treatment from 6 months to 1 year. So, but most of the people who were there also, they were giving ATT for 1.5 years for CNS tuberculosis. So this is the issue. We still don't know what is the adequate number of tuberculosis ATTs or the duration of treatment that should be given to these patients. So I was just wanting to touch on the challenges that we face, but I still believe that even with the advancement in the diagnosis and treatment, if pulmonary tuberculosis becomes better, I feel that the benefit will be reflected in the CNS tuberculosis as well. So thank you so much.
Thank you, Dr. Paliwal. Am I audible?
Yes, ma'am.
Thank you, Dr. Paliwal. That was really an excellent talk, and I really liked your last slide. The comparison of CNS TB with pulmonary TB. खरगोश और कछुए की दौड़ जारी है, और इसके अलावा ये भी हमेशा एक इम्पॉर्टेंट डिबेट रहेगी कि ड्यूरेशन कितनी शॉर्ट करें कि बेनिफिशियल हो, कॉस्ट बेनिफिट रहे, एट द सेम टाइम रिलैप्स नहीं हो या inadequately treated TBM नहीं रह जाए. You know, when you are treating for too long, you are exposing the patient to toxicity. If it's a lady who is in reproductive period, that means that we are asking her to postpone her pregnancies for that long. So these are the practical problems when we treat. And at the same time, to treat for long enough that the patient does not have a relapse or he does not have an inadequately treated disease. So like you said, that you yourself were part of the index guidelines, which not everyone even follows. But, you know, this is always an important debate in everyone's minds. And I guess that only time can tell. Another few years, and we'll have maybe a better head-to-head comparison of how many patients have been actually only treated for 6 months, how many for 1.5 years, how many for 9 months, etc., etc. We are looking forward to a study from you on this.
Yes. I think that a single yardstick cannot answer this question of duration.
Exactly.
I think we need to have a composite of clinical features, radiological things, and past histories to take into account and then formulate the guideline.
Absolutely. Thank you so much. Thank you for your talk.
Thank you so much.
I now invite Dr. Amit. He is a young faculty member in the Department of Orthopedics. Orthopedics is a new department in SGPGI. I am trying to look for the slide about his resume. Meanwhile, Dr. Amit, are you here?
Yes, ma'am.
Okay. Can you share the slide about your resume, Dr. Amit? अच्छा, आपने अपनी, so Dr. Amit is a new, this slide says it all. He's an assistant professor in orthopedics in the Apex Trauma Center, which is with Sanjay Gandhi PGI. He is one of our very young faculty members. I thought after neurological tuberculosis, we should talk about orthopedic tuberculosis. So Dr. Amit Kumar is here to enlighten us about some salient aspects of osteoarticular tuberculosis. Over to you, Dr. Amit.
Thank you, ma'am. It's been a wonderful talk to be here, and I'm thankful to you for giving me this opportunity to talk on this osteoarticular tuberculosis. I would like to start with the words of Professor Sam Sundaram, who used to say that tuberculosis is probably as old as mankind, and its continued presence made us a sorry tale of missed opportunity and mismanagement by medical profession. Osteoarticular tuberculosis, or also known as bone and joint tuberculosis, is 1 to 4% of the total tuberculosis case, and it appears to follow the trends of pulmonary tuberculosis. The study has suggested a high incidence of resistance of tubercular bacilli in osteoarticular tuberculosis. Pathogenesis, as the disease spreads from primary focus by hematogenous route, and osteoarticular tuberculosis is often a osteoarticular lesion that have been implanted at the time of initial bacterium. There are two basic types of disease pattern: exudative type, which is most commonly found in children, and granular type, which is common in adults. Out of 206 bone, spine is most commonly affected and constitute nearly 50% of the total osteoarticular tuberculosis. Next in order of frequency is hip, knee, and elbow joint. As tuberculosis is a chronic and slowly progressive as well as destructive disease, it often results in walking difficulties and disabilities. It can affect any gender or any age group. Patients with osteoarticular tuberculosis present to us as pain, deformity, and characteristic cold abscess, sinuses, tubercular ulcer, with or without classical constitutional symptoms. On examination, they may have muscle wasting, localized tenderness, regional enlarged lymph nodes, or painful restriction of adjacent joint movement. Occasionally, there may be presence of cold abscess that becomes subcutaneous and penetrates ligament, bone, and periosteum along the chest wall or iliac fossa. Broadly, osteoarticular tuberculosis of three types: tubercular osteomyelitis when there is involvement of bone, tubercular arthritis when there is involvement of joint, and tuberculosis of spine or the spinal tuberculosis. Specialized to the disease space from surrounding tissue or through vascular supply, and it causes discitis. As infection progresses to the vertebral body, it produces osteomyelitis, and subsequently, when the vertebral body degenerates and collapses, the kyphotic deformity known as post disease ensues. Later on, abscess or granulation tissue or deformed vertebra can compress spinal cord to cause neurological dysfunction. In children, osteoarticular tuberculosis poses an alarming threat as they have open physes. If untreated or treatment is delayed, it can lead to functional disabilities. Infection is spread across the physes and produces multifocal cystic bone destruction, which involves both proximal metaphyses and epiphyses. So, it is important to have early diagnosis and treatment to prevent serious bone and joint destruction. With the emergence of multi-drug resistance, it is essential that the adequate samples are collected to take advantage of available molecular diagnosis for early detection of drug resistance in children. When we see the practice across the globe, surgeons in endemic area often tends to overdiagnose tuberculosis due to patients' load and improved perception, and they mainly rely on clinical radiological diagnosis. Whereas in surgeon in non-endemic area tends to underdiagnose tuberculosis. So, are we diagnosing properly? With a big question. As in osteoarticular tuberculosis, accurate diagnosis is difficult due to deep inaccessible lesion, possibly acidic states, and initiation of empirical antituberculosis in most of the cases. So, it is important that all cases must be subjected to panel of investigation. This should include AAP staining of culture, PCR or gene expert, histopathological examination. In particular, serological test alone is not diagnostic. Tissue diagnosis is the gold standard. An appropriate sample must be obtained whenever we suspect a case of tuberculosis. Cotton swab specimen from this discharging sinus should be avoided. Tissue can be obtained by biopsy under image guidance during open surgical procedure, percutaneous transperitoneal biopsy, and arthroscopy. There are various radiological modalities such as X-ray, MRI, CT, nuclear imaging that helps in proper diagnosis and staging, planning surgical treatment, and follow-up of the osteoarticular tuberculosis. Treatment of osteoarticular tuberculosis requires a multidisciplinary approach. It should include physician, surgeon, physiotherapist, nutritionist, and social worker. The aim of treatment is to control infection and care of the disease part. As most of the cases respond very well with the conservative therapy, and only few require surgical intervention. Conservative treatments includes rest and bracing or splintage, traction and proper positioning of the affected part, anti-tubercular drugs, building up of the patient's resistance, and later mobilizing physiotherapy of the protected vein. Regarding anti-tubercular drugs for osteoarticular tuberculosis, it is same as a pulmonary tuberculosis. However, there has been a lot of discussion regarding optimal duration of the drug therapy. Previously, longer therapeutic course of 18 to 24 months were given because of concern of poor drug penetration. Recently, WHO recommends a minimum of 12 months of anti-tubercular drugs for osteoarticular tuberculosis. For MDR tuberculosis, in the osteoarticular tuberculosis, the total duration of treatment should not be less than 18 to 24 months. Surgery has very limited role and it has just an adjunctive role in cases with inadequate response. As this is a case of severe kyphotic deformity with active tubercular spondylitis, and surgery was done for the correction of kyphotic deformity and spine was stabilized by pedicle system. This is another case where the total hip replacement surgery was done for tubercular arthritis of the hip joint. The joint has completely been destroyed. Another case where total knee replacement surgery was done for tubercular arthritis of the knee joint. Take home message is tuberculosis is an indolent disease, and one should have very high suspicion when X-ray is showing suggestive change of clinical trial. Diagnosis should be confirmed by biopsy and culture of the infected material. Anti-tubercular drugs remain the mainstay of treatment. Surgery is indicated in cases with inadequate response, and comprehensive care of osteoarticular tuberculosis is a team approach. We must put our hands together to end this menace of tuberculosis. Thank you, ma'am.
Thank you, Dr. Amit. That was a very big topic you covered in a record short time. One thing which Dr. Amit highlighted, which is very important, is that drug therapy must always be guided by susceptibility testing. Nowadays, we are going towards drug sensitivity testing in 100% of TB. जहाँ भी हमें बैक्टीरिया मिल जाए, हमें उसकी susceptibility testing करनी है. हाँ, बहुत जगह पे हमें बैक्टीरिया मिलता ही नहीं है. We have to go by clinical suspicion, that is still there. But in that scenario where we can get Mycobacterium tuberculosis, we must go for drug susceptibility testing. That was a very important carry-home message, and that surgery has not that much role, even though orthopedic surgeons would always like to say कि surgery का role है. Surgery still has limited role. It is medicines which play the ATT which plays the main role.
Major role.
Early diagnosis, correct treatment. These are the mainstays of treatment and drug susceptibility testing. Very nice talk, Dr. Amit. Thank you very much. We are now coming towards the end of our talks. Our second last talk is by Dr. Indu Lata. She is a faculty in our Department of Maternal and Reproductive Health. And I have kept her talk towards the end because it's a very, very important talk. Because I didn't want anyone to think that last is the least. Actually, this is a very, very important topic. Genital TB, again, like CNS TB, orthopedic TB, remains an enigma. Very difficult to diagnose at times, very simple to diagnose at times, how to diagnose, how to treat. And the most important problem in India is that it is a very important cause of infertility, which if treated, if diagnosed and treated well in time, patient can be rid of her infertility. But if it goes on untreated, then of course, I don't think then it remains treatable after some time. So Dr. Indulata is the best person to talk about this. She's additional professor in our Department of Maternal and Reproductive Health. She has a lot of publications, awards, and honors to her credit. And well, she's a very dynamic consultant and is always working with genital TB and infertility patients. So over to Dr. Indulata. Dr. Indu, should I share your slides or will you share your slides yourself?
I will share, ma'am.
Okay.
Thank you, ma'am.
Please go on. ये इसको stop sharing करते हैं. Yeah. Now you can share.
Okay, ma'am. Okay. Am I audible, ma'am? Hello?
I know you are audible, full screen.
And my screen is visible?
Yeah, full screen for me.
Okay. So today's topic, which is very important, that is genital tuberculosis, and it is very, if we see the rate of infertility is increasing day by day, and the one of most important cause for increasing infertility incidence is genital tuberculosis. So my screen is not moving actually.
Indu, you have to go full screen. You have to do a slideshow. Slideshow karo.
Okay.
Now it will go.
Okay, for introduction, genital tuberculosis usually occurs secondary to tuberculosis in other side. That is, it is always extrapulmonary tuberculosis, and the primary is usually in the lung. So the overall genitourinary tuberculosis accounts for 27.1% cases of extrapulmonary tuberculosis, and in that genital tuberculosis only, that is TB of genital parts, is only accounts for 99% of all extrapulmonary tuberculosis. So what is the affection of tuberculosis in genital organs of the female? So most commonly affected part is the fallopian tube, that is up to 100%. It can affect up to 100% the fallopian tubes, and followed by the uterine endometrium and the other genital organs like ovaries, cervix, uterine myometrium, and vagina and vulva. So in clinical feature, it can present in any age, but it is the most commonly affected age group is the women of reproductive age group, that is 15 to 45 years. And in most of the cases, it remains asymptomatic. But if it present, then infertility is the most common presentation in this age group of women. The other symptoms are menstrual irregularities like oligomenorrhea, hypomenorrhea, amenorrhea, menorrhagia, metrorrhagia, etc., along with pelvic pain and abnormal vaginal discharge. So diagnosis should be by thorough systemic clinical examination with high degree of suspicion and use of intensive investigations. And we can suspect the genital tuberculosis in patients with chronic pelvic inflammatory disease not responding to standard antibiotic treatment, patients with unexplained infertility, patients with irregular menstrual cycles or postmenopausal bleeding, and persistent vaginal discharge where genital neoplasia have been ruled out. And if there is no single, and after that, there is no single diagnostic test available to confirm the diagnosis of female genital tract tuberculosis. So as all evaluated the investigation in these patients, we can go one by one, that is blood test, in which we usually do the complete blood count with ESR, in which the ESR can be raised in the genital tuberculosis. The X-ray chest PA view to see the primary for the genital tuberculosis, and we can also do the Montauk's test, but the sensitivity and specificity is very low. So on the basis of only positive Montauk's test, we cannot treat the genital tuberculosis. In these patients, patients with infertility or the patient who is showing us for infertility, then we go for hysterosalpingography, ultrasonography, and CT and MRI. In these investigation, we can catch the unilateral or bilateral tubo-ovarian masses with ascites due to tuberculosis, hydrosalpinx, tuberculous deposit on the peritoneum, and enlarged lymph nodes. So these are some pictures showing the some pictures of hysterosalpingography in infertile patient, in which first picture is showing the bilateral cornal block, that is both tubes are blocked at the cornal end. The second picture is showing there is dilated left side tube along with fimbrial block. In third picture, the tubes are in beaded appearance. That tubes becomes just like the beaded appearance. And in fourth picture, it is showing the pipe-like structure, that is straight pipe-like structures. These are the pictures on the ultrasound. On ultrasound, we can get the tubo-ovarian masses like this, and hydrosalpinx, that is the fallopian tubes are filled with fluid. The endometrial cavity, in which there is various adhesions, intrauterine adhesions, which hamper the implantation. So it is also a cause of infertility. And in fourth picture, there is calcifications in the patients with genital tuberculosis. The another technique is to diagnose the genital tuberculosis is direct endoscopy, that is by laparoscopy or by hysteroscopy. In laparoscopy, we usually see the genital organs, the intrapelvic genital organs by our eye. So in laparoscopy, patient can present as the normal appearance, or patient can have the tubercle on the surface of uterus, ovaries, and tubes also. And there may be fimbria block, fimbria phimosis, tubal beading, peritubal adhesions, tubal ovarian masses, and hydrosalpinx. And hysteroscopy is an endoscopy in which we see through the inside the uterine cavity by the endoscope. So in genital tuberculosis, the endometrium looks like pale, and there may be presence of tubercles, small white cages, nodules, intrauterine synecdoche, and Asherman syndrome. And the gynecologist who is performing this hysteroscopy may face the difficulties in performing hysteroscopy due to the small shrunken cavity due to genital tuberculosis and fibrosis. These are some pictures taken from the laparoscopy in which there is tubercles are present on the surface of uterus and tubes and ovaries. In second picture, this is showing the omental adhesions. Patient can have adhesions, intrapelvic adhesions, intra-abdominal adhesions without any history of any surgery. In third picture, this is showing the large tubular masses, and all the nearby organs are also adhered to these masses. And in fourth picture, there are presence of some cases, nodules, and adhesions between the liver surface and the parietal peritoneum. It is also called as Fitzhugh-Curtis syndrome. So regarding the diagnosis, so first we have to take the histopathological examination of tissue for genital organs. So usually to diagnose the genital tuberculosis, we take endometrial tissue or curettage or aspirate the content from the uterine cavity, and for the diagnosis of tuberculosis by histopathology. So in histopathology, the presence of caseous granuloma with or without giant cells, Langen giant cells, is diagnostic of genital tuberculosis. So and another test is acid-fast bacilli staining and AFB culture from the tissue in which we are seeing we are going to test whatever the tissue. And it is already said that it is very difficult to get the acid-fast bacilli in the staining. And the another test, which is polymerase chain reaction, it has high sensitivity and specificity, but it has high false positive rate because it also take into account the dead bacilli also. So on the basis of positive PCR reaction, PCR test, we can't start ATT in genital tuberculosis. The next two advanced tests are CBNet and Gene Expert. The by CBNet test, if there is positive test, then it is okay. But if there is negative test, but it does not rule out the tuberculosis. And the Gene Expert test has low sensitivity but high specificity. So none of the available tests were sensitive enough to diagnose all cases of genital tuberculosis. So it is advisable, clinicians should not initiate ATT for patient only on the basis of single positive test and should correlate with clinical evidence and laparoscopic findings. So in treatment, the treatment is same as pulmonary tuberculosis. And in patients with organs sensitive to first-line drug, 6-month regime is given, that is HREZ for 2 months, and isoniazid and rifampicin 2-drug therapy for remaining 4 months. And for defaulter cases or relapse cases, we can give 5-drug regime for initial 2 months, followed by 4-drug regime for 1 month, and then followed by 2-drug regime for 5 months. That is total 8 months. And in multi-drug resistant cases, we can give these antitubercular drug for 9 to 12 months. In patients in which there is tubal blockage due to genital tuberculosis, then and there is normal endometrium, then these patients can go for in vitro fertilization like IVF, embryo transfer. And in patient in which the endometrium of the uterus is damaged due to tuberculosis, due to some intrauterine adhesions, then in that cases, the patient is advisable for surrogacy. And if the ovaries are affected due to tuberculosis, and then these patients are for the in vitro fertilization by donor egg, or there is option for adoption. So this is all about the genital tuberculosis. It is very difficult to lay out the good big topic in some slides actually. So thanks to ma'am for giving me this opportunity to be in this CME. Thank you, ma'am.
Thank you, Dr. Indu. I agree with you that it's a massive topic, and well, you did touch upon all the very important salient aspects. It's yes, and I think your carry-home message that there is no single test which can diagnose clearly genitourinary tuberculosis. It has to be a combination of history, clinical suspicion, clinical examination, and then the tests which are corroborative. Most of them are just corroborative. It's only very once in a while that we will be able to see AFB, or we will get gene expert positive, or we'll be able to get histopathology positive. Rest of the time we just have to, it's like a jigsaw puzzle, and we just put everything together. That was a very, very nice talk and very important topic. Thank you, Dr. Indu.
Thank you.
Thanks a lot.
माहौल light करने के लिए, I'd just like to say something over here.
Yes,
I was
please.
telling you the other day that मेरी mother-in-law को शायद genital tuberculosis मतलब fallopian tube block था, possibly due to tuberculosis. And 14 years after, she was given a dhamki that दूसरी शादी करा देंगे. So my father-in-law very lovingly took her to Tureganj hospital. They did an HSG, hysterosalpingography, and my husband was born after that. So sometimes diagnostic procedures are helpful not only in diagnosing but actually curing the malady as well.
Yes, ma'am. Yes, ma'am.
So that's one story of TB with a very, very happy ending.
Yes.
No, Dr. Pyali.
That is a happy ending, yes.
Yes. So I'm sure Dr. Indu has many, many such patients. So all the best, Dr. Indu, and thank you so much for this very lucid talk. We now go on to our last speaker of today, which is our friend from General Hospital, the dermatologist, Dr. Ajit Kumar. He is the iklauta dermatologist, the iklauta chamdi wala doctor in SGPGI, so very much sought after. And जैसे कि हमेशा कहते हैं कि सिर्फ स्किन डीप, सिर्फ सुपरफिशियल, लेकिन that's not true. Skin is actually a very, very important organ of our body. And now we are not seeing skin TB that often, but people who are my age will remember that when we were doing MBBS and MD, we used to see skin TB very, very often. I think Dr. Ajit will agree with me. We used to call it scrofula. And now we don't see it that often actually, but Dr. Ajit has shown me a few cases. So I'm thankful to him for that. And over to Dr. Ajit for now for his presentation. Dr. Ajit, do you want to share your slides or shall I share?
Yeah, I think I'll share. I have them.
Okay, okay. So Dr. Ajit is actually really modest, and he's not sent me his CV also, but well, I think everyone knows him as the one and only dermatologist in SGPGI who has a lot of experience in skin diseases to his credit. Over to you, Dr. Ajit. I think Dr. Indu has to stop sharing the screen.
Exactly what I was about to say.
Dr. Indu has to stop sharing, then Ajit can share. Ajit, आप अगर अपना share करोगे तो उनका चला जाएगा अपने आप. हाँ, okay. Now you go full screen. Now you go slideshow.
Slideshow.
Yeah. अब आप slideshow करो तो फिर then it will go properly.
Now it's good evening to all of you. And to talk about the largest organ, I have the least amount of time. So it will be the shortest one. More often than not, cutaneous tuberculosis, we miss them. And with the rampant misuse of steroid topically, we miss them. But awareness is important. We should not be doing such things. So it's a starting advice to one and all, maybe also those on the YouTube. So avoid misuse or haphazard use of topical steroids. Cutaneous tuberculosis has a wide range of presentation. As one can see, we have 4 different pictures, photographs, and all 4 look entirely different. Why is it so? Because it depends how the mycobacterium has reached the skin and the site. And also, what is the immunity status or nutrition of the patient. It can be acquired through exogenous inoculation, means directly onto the skin, or from a contiguous spread. That is, one organ is already infected and somehow the skin is in contact with it and gets infected at the same time or following it. The third is the hematogenous dissemination. And the fourth one is the tuberculin. This is very interesting. It is thought to be a hypersensitivity reaction to Mycobacterium tuberculosis. And it includes papillonecrotic tuberculin, lichen scleroforum, and erythema induratum of disease. The primary inoculation tuberculosis, which was earlier seen, is very rare nowadays. It has 2 other names in the textbooks or literatures, tuberculous chancre and primary tuberculous complex. It results from the direct entry of the organism into the skin of a non-sensitized individual, which is nowadays rare with vaccination and all that. Used to be seen usually in children. This is one of the very common ones. This is a form of cutaneous TB that occurs after direct inoculation, but in a previously sensitized host with moderate to high immunity against the bacilli. Commonly known as watery tuberculosis. This has got very many names. Prosector's node or prosector's wart, anatomist's wart, and more technically tuberculosis varicosa cutis. Scrofuloderma, Dr. Piali has touched upon it. This is a form of cutaneous TB that occurs frequently prior to used to occur frequently prior to the advent of effective therapy of TB. And this was more common following TB of the lymph node and sometimes also the TB of the bone, where the bone was subcutaneous rather superficial. This also occurred more often in the children and adolescents and the older adults. Tuberculosis cutis orificialis or orificial TB. This is not so common, you can say rare. This has got a very interesting means of developing. It is an auto-inoculation, where the primary TB is somewhere in the deeper organ, maybe the lungs, then the site becomes the nostrils, or sometimes even the mouth. When the patient or the subject is coughing out the AFB. Rarely, it may be the anogenital skin or mucosa as auto-inoculation from the gut. And lupus vulgaris, this is the most common. This has got multiple ways of spraying. It can be hematogenous, it can sometimes be direct inoculation also. It is chronic and progressive form of cutaneous TB and is commonly seen in people with moderate to high immunity against the bacilli. Metastatic tuberculosis abscess or tuberculosis gamma is again now rare with the advent of very good anti-TB drugs. This used to arise as a consequence of hematogenous spread of the bacillus from a primary focus of the infection to the subcutaneous tissue during a state of reduced immunity. And this usually occurs in malnourished children and immunosuppressed adults. Miliary TB is yet another form of TB, which is a disseminated form, and the technical name Tuberculosis cutis miliaris disseminata is more of a descriptive nomenclature rather than a proper name, and it results from the hematogenous dissemination from a primary focus of infection, maybe the lung. And once again, this occurs in individuals with impaired cell-mediated immunity, such as the patients with AIDS or those who have been taking systemic steroids without a proper consultation, and the tuberculosis, the pathogenesis of which are not fully understood, but there is always a failure to detect the organism in the affected tissue. But at the same time, there is presence of detectable extracutaneous tuberculosis infection at a site distant from the lesions where we are examining primarily. And there is histological evidence for granulomatous inflammation in skin lesions, similar to what is seen in TB lesions. And the last but not the least, the resolution occurs frequently with the anti-TB therapy of the primary condition. This presents in 3 different forms, namely papillonecrotic tuberculate, which is the most common frequently nowadays. And the most interesting one is erythema induratum, which is usually seen in the posterior calf side with induration, which is mildly painful and often is confused with erythema nodosum. All of these are easily visible as with dermatology. Inspection is the gold standard of our diagnosis, whereas the diagnostic techniques, the culture is the most important, or what we say as the gold standard for diagnosis. And here also we rely more on the stained smears and the lesional biopsies. Tuberculin skin testing, interferon gamma release assay, PCR, these 3 are not so frequently utilized by us. We rely a lot on the culture of the smears and the biopsies. When in doubt, we even go for therapeutic trial with anti-TB medications, even when we are not confirmed with the diagnosis of TB in difficult cases with limited resources. But as far as the treatment part is concerned, we do not interfere much with what is there in the National Tuberculosis Elimination Program, and we stick to it as for extrapulmonary TB. I hope I am not taking too much of time.
Okay, is that?
Thank you.
Is that over? Thank you, Dr. Ajit. That was very, very crisp, I must say. The spectrum of skin TB, even though, like you said, it now has become very rare. Thanks to you, I have seen a few cases even now, which we don't see that often now. But the spectrum is actually really vast. And to still have the high index of suspicion is important. That's how you catch on to them. Otherwise, otherwise you just write quadriderm and send people off. You know, there's nothing else. आप मरीज आया, उसको स्किन में कोई रैश है, उसको क्वाड्रिडर्म लिखो और उसको भेज दो. But if you have it in the mind, that's when you look for it. Okay, yes, this is India, TB is rampant, this could be skin TB. So that's what is really important. उस बाकी सब उसके बाद आता है, पहले हमारे माइंड में होना चाहिए. So thank you. That was a very crisp talk, and it brings us to the end of our session. I must say that there were a lot of talks today, back to back, and it was all very important aspects which got covered. Everyone's talks were, despite a very short time allotted to everyone did justice to whatever was their topic and stuck to the topic and stuck to their brief. They talked about the topic allotted to them in a very clear and grounded manner. So, and I don't think anyone got bored, no one slept. So everyone was awake, everyone listened. Thank you to all my speakers, to all our panelists today, and to the two organizers. And now I invite Dr. Anju Rani, who's our senior gynecologist in General Hospital SGPGI and colleague and friend, to give a vote of thanks to all our panelists, speakers, and organizers today. Over to Dr. Anju.
Thank you, Prerna. It's really most pleasant duty to do the vote of thanks. First of all, I would like to thank our Director, Professor R.K. Dhiman, and Dean, Professor S.K. Mishra, for giving their valuable time and blessings. And I think Dr. S. Santosh Gupta, the State Tuberculosis Officer, he gave very good insight about tuberculosis. And I think tuberculosis in India, the picture in the world map, and also the burden of tuberculosis of our state, and how what are the programs and how we can eradicate this problem. So beautifully he he demonstrated all these things. And I thank all the panelists, Professor U.C. Ghoshal, Professor Surya Kant, Professor Vimal Paliwal, Dr. Pyali Bhattacharya, Dr. Ajit Kumar, Dr. Amit, and Dr. Indulata. They all did really justice to their topic, because they all were within their time, and the illustrations of each specialty were superb, very good. I thank Dr. Prerna Kapoor especially for super moderation of this session, and thank Dr. Rama Tripathi for very well coordinating this whole webinar and organizing this beautiful and very informative session. And especially I thank Dr. Pyali Bhattacharya, our dynamic pediatrician, for making all of us glued to each other. And last but not the least, all the participants who logged in and participated in this event, and probably they took some message to eradicate this tuberculosis from India and at last from the world. And thank you all once again. Soon we might meet with some very interesting topic again. Thank you so much.
Thank you, Doctor.
Anju, can I add to that? I need to thank the people in telemedicine who have actually helped me so much, and Ripu and all the others who've been with us. Thank you so much to them too.
Definitely.
For all those who missed the program on Zoom, it will be streaming on YouTube also. It is already streaming live and it will be there available. Everybody can see, people can see Dr. Indulata's slides whenever they want. They there's some slides were so detailed, they were so good that we can go back and see those slides again and again. So we can look into anyone's slides and listen to everyone's talks whenever we want.
YouTube, anybody can anytime can see it. Okay.
So, thank you.
Thank you, everyone.
Thank you, Dr. Pyali. Thank you, Dr. Rama.
Thank you, everyone.
Thank you, ma'am. Thank you.
Thank you to
Rama, we have your permission to leave now.
Okay.
Thank you.
Good
night.
Thank you. Namaste, ma'am.